we say, well, you must be crazy, right? Because we have to put a name on it, and if you can't name it, then we go, well, it's not real. You know, it's in your head, or it's drug seeking, or it's this, or it's that, or it's the other thing. And it isn't that. It's a whole bunch of different things that we don't understand. So just because we're ignorant, you shouldn't view that as, you know, as your problem. It's our problem, and we'll solve it. Okay, so let's get into it. Here's just pictures. We're a fairly fun program, and so we get lots of crazy pictures from different people. You see up in the corner there, that's whenever we take somebody off of TPN, we always take lines in on Fridays, because then we all go out and we go to drinks afterwards, and we all celebrate together, and get the team and the patients together. And you can see that mom in the corner, that was the first time there was a legitimate poop in her baby, and she said she would send me a poop warrior picture, so she put the poop makeup on her face and took a picture and sent it in. So what we'll talk about today is what we do. You know, I work with a couple of the major companies in the field, just working on the new developments in teduglutide and glucagon. Okay, so intestinal failure. This is a room where most people get this. Okay, doctors understand heart failure and renal failure and respiratory failure. They're sort of easy, intuitive things, but intestinal failure is something people don't think about. So when you go to your small town, they don't really know that it's not something they think about normally. If you can't maintain your own state of health with your own intestines, basically your hydration and nutrition, anything other than that is intestinal failure. Okay. Now, what are some of the causes? Well, for pediatrics, it can be that something happens when you've lost some of your intestine, so you don't physically have enough, and these are some pictures of different causes that we see in kids. Or it can be functional things. You have enough intestine, but what you have just doesn't work good. So there's different, different things like microvillus inclusion, or if you don't have nerves. Pseudo-obstruction, actually, and we could do a whole talk on that. Because the thing with pseudo-obstruction is, it's because doctors have to attach a name to something. Pseudo-obstruction means, well, like obstruction, which means don't know what it is, right? so that's why we use that term. We're starting to discover it's actually a whole bunch of different things. So there's a whole new field coming of active mutations, discovering why muscles can't contract, why nerves maybe aren't conducting properly. And so we can start to take it past that diagnosis and start to figure out why it is and get right to the core of what the problem is and hopefully fix it. Adults tend to follow the same sort of thing when you're breaking down causes. Either you don't have enough intestine or you have enough but it just doesn't work good. And in adults, what I see more, it tends to be either catastrophic or non-catastrophic. And so catastrophic things are something bad has happened, a blood clot, a gunshot wound, a car accident, a surgical misadventure, a problem with the surgery, and boom, life is transformed. 1 week, everything's cool, you haven't thought about your intestines ever. Next week, bam, short bowel syndrome, all new words, all new life, TPN, everything else. The non-catastrophic patients are more like where it's just been, it's an operation, it's a little something here, a little something there, and somebody suddenly says, well, we should put some TPN for a couple of weeks and just tune you up. And then after 2 weeks, you don't quite come off. And then 4 weeks have passed, and then 4 months have passed, and then 4 years have passed. Okay. So let's set out just some sort of conceptual stuff, some little framework. I'm going to try not to run over, but I'm probably going to run over like 10 or 15 minutes, so brace yourselves. Don't wave the signs. So your goal is to take 100% of everything down. Yeah, just doesn't matter. So your goal is to take 100% of everything down. Now let's imagine that you take nothing but enough. Okay, so how do you get there? Well, you can do 2 different things. One, you can do transplantation. And I'm going to actually talk about that first and fairly quickly because I get a lot more jazzed about the rehab part of things. So if I do the transplant last, it kind of feels like it's an also ran, so I throw it in the beginning just so I don't forget. So transplantation means what you have just isn't enough. Let's give you new something. Let's give you new stuff. Everything other than that is rehabilitation, which is to say, okay, what you have isn't perfect, that's not terrible, and let's see what we can do to try to get you to that end goal using what you have. And these things should work together. So it's not like one is a failure of another. If you do rehabilitation, you shouldn't say, oh, transplantation is a fail. And transplanters shouldn't say, oh, rehabilitation is a waste of time. Don't make these people suffer, just transplant them. These things should work together. You should try to rehab everybody. And then there will be some people who you can't. And when you can't, then you turn to what the next thing is in your pocket, which could be transplant. So you look at the risks up front and you decide which pathway you have to go on. And I can tell you that for all the patients we see a year, we probably see maybe 80 to 100 new adults and maybe 40 new kids a year, and there's maybe 1 or 2 who go to transplant right away. The majority tend to come to rehabilitation, so it's overwhelmingly that path. And you can move back and forth. So we've had patients who are listed for transplant who we go, gee, you're doing pretty good, let's take you off the list for a while. Conversely, we've had patients we've looked after for years and we go, well, something's changed and we should really get you listed for transplant so you can move back and forth. Okay, so who do you actually transplant? So when you talk about transplant and Medicare and stuff, there's sort of classical indications. And the classical indications are if you have liver failure from your TPN. And that's not just like your enzymes are off a little bit or anything. That means you have functional impairment of your liver, where you have cirrhosis, bleeding, encephalopathy, all kinds of different end-stage complications. Just a little bit of liver stuff is a long, long ways away from transplant. If you've lost your central venous access, so if you think about TPN as life-saving, you need veins to get life-saving therapy. If you don't have veins anymore, we can't provide that therapy. Now, we can get pretty fancy with trying to find access, but it's something we have to think about, especially if you're young, right? If we have somebody who is 15 years old and we want them to live 70 years, well, we don't want to go to the very last vein in their body when they're 16 years old and then say, okay, are we going to limp along with the transhepatic line for the next 60 years? I'm not interested in 5-year survival. Doctors talk about 5-year survival. It comes out of cancer literature. We're not interested in 5-year survival. We're interested in all life survival. Right? We want everybody to grow up and die of an unrelated cause when they're 100 years old. So we have to get away from thinking about 5-year survival. We have to think about our whole life. If you have multiple episodes of sepsis, that could be a reason. You might say, oh my gosh, if I get sick with that again, I'm going to die. So I need to have a transplant to try to prevent that from occurring. And then the last thing would be if you're unreconstructible. So some patients who have maybe just their stomach and their duodenum and then a little bit of rectum, and there's no way to join the two things together. And then you say, even that isn't like an emergency, because you can do lots of stuff to keep people healthy, but ultimately you're probably going to have to go towards getting something. Now the reality is, we don't see a lot of TPN-associated liver failure, end-stage liver failure anymore. We see it tweaking the liver, but in general, we're pretty good at managing that. So it can still occur, but it's way less common than it was a decade ago. Likewise, we don't really get a ton of bad life-threatening infections anymore. There's lots of ways we can take care of them. I think we're starting to hit at the underlying causes, so they don't happen as often. So we end up more with loss of venous access and some of the really bad, surgical things that are more reasons for transplanting. All right, so let's see. We can do, basically for intestines, there's two main things you can do. An isolated intestine, so you take an intestine and it has an artery leading into it and a vein leading out, and you can basically take all that's in there and pop the new thing in and join up the artery and the vein, and that's an isolated intestine, or isolated. Sometimes when I talk, forgive me if I might say small bowel, I might say small intestine, I might say they're all the same. Surgeons just flip back and forth. So likewise, if I say large bowel, large intestine, or colon, I mean the same thing. And sorry if I sometimes do it without thinking. And we can also do a combined liver, pancreas, intestine transplant. And so that's a little different. I have a short video I'll show you. But you can think of it like grapes on a stem. And the stem is the aorta. And so the aorta brings in all the arterial blood. And we can, believe it or not, just kind of add organs onto the stem. So a liver, pancreas, intestine, you think, wow, that's way more stuff than an isolated intestine. Really, it's not technically that much harder. It's similar in magnitude operations. Okay, so I'll show you an example of a liver bowel transplant. I actually need to update this because it's getting kind of dated. But this is a pediatric transplant. So here what you'll see is, this is my partner when he was doing this transplant. We get the organs and they're maintained in a cold preservative solution. And we have to clean off some of the structures around there. So there's the vena cava above and below the liver. This one's fairly small, and you'll get a sense of size as you see this relative to the hands. So there's what's called the aortic conduit, and we sort of clean all the tissue off the aorta, and we tie off all the little branches. So there's little silk ties on those branches. And we're just cleaning up the blood vessels in preparation for where we're going to put things in. We're just pointing at some anatomy, and some of that we're actually going to get rid of. You get a sense of size there because you can see there's the pancreas and the spleen, and so that spleen is about the size of your thumb. So this would be a pretty small donor. This would be something we'd be putting into a fairly small child. Just pointing out some of the different anatomy and the structures of the gallbladder there. When we do a liver bowel like this, we leave all the complicated structures like the center of the liver intact, so we don't have to work on really small things. We sort of work more on the outside of the bigger vessels, which just makes it more technically straightforward. It takes maybe about an hour to get the organs all ready. So typically we're either putting the patient to sleep or we're actually starting on the other part of the operation while someone's doing this on what's called the back table. So someone's doing the back table while somebody else is operating. So here's just a brief sense of an operation. We usually use whatever incision is already in existence. So this is a long midline incision. And you'll get a sense here. There's the liver. This is a sort of old school cholestatic sick TPN liver. And this liver is right down, out of that child, down into the child's pelvis. So that's how big it's gotten. It's occupying all this space. So you can see, we can pop the whole thing out of the abdomen. That actually creates a bunch of space for us to put the new graft in. And so now we just divide the structures going up to the liver. We each do this a little differently. I think mine is prettier, but it's all big. So we're just doing some rearranging of blood vessels and stuff in here. In this case, we did something called a portocable shunt, which is just an extra little technical variation. But so now we get into a scenario where we're putting clamps on. So we have a clamp that's up above the clamps that's below the liver, and clamps that go above the liver. We sort of bring things up and just kind of test it and go, yeah, does it look like it fits okay? And at this point, you really hope it does, because you move. No, just joking, we always And so out with the bag. So now we're staring at this abdomen where we've really removed most of the viscera. We just have the aorta, the cava, the back, and the kidneys. And there's a clamp at the top that's below the heart. And so now we kind of clean things up. We're going to take a little piece of that aorta and sew it onto this child's aorta. And that happens just here in a second. That's called a conduit, a little aortic conduit. It's usually, I don't know, maybe 3 inches long, 2 or 3 inches long. So we're sewing them on with some little tiny chromium sutures, same stuff as fishing lines made out of. And then we'll put a little clamp on that, pop that clamp off the aorta, let that expand up. You can see the heart beating up in the top there, actually. It's kind of neat. You can see it wiggling on the other side of the diaphragm. And that, we're just below the diaphragm there where that clamp is. We're going to sew the vena cava of the graft to that upper clamp just above the weight there. So the graft comes up legit for real now. And yeah, it's just a matter of now we're going to do, we sort of put some stitches in. We start the sewing on the outside of the body and then drop the liver in. And we're finishing up the cava above and the vena cava below. And then we have to, maybe we left that little piece of artery that I showed you guys a couple minutes ago. We have to sort of join that back onto the artery that goes to the graft right there. So we sew those things together. And then you pop the clamps off and you see what is, I would argue, is my most favorite thing in all of surgery, because it's quite beautiful. You just see everything reperfuses. And then you have nice, normal, pink, healthy viscera, and it starts to peristalse right away, and it's really quite incredible to actually see it. It's just like, really like a renaissance. It just comes to life. Okay. Now, here's the thing with transplant, is that no matter how awesome you are as a family or as a patient, or I am as a surgeon or any team is, the statistics are what they are. So it's a great therapy when used in the right circumstances, but no matter how good we do, there is a finite death that occurs with it. There's a finite mortality rate. And so we can never take it lightly. We can never just say, oh, well, just do a transplant. Because if I told you you had a 1 in 5 chance of dying in 5 years, well, especially if you're young, that's not so awesome. You want to really think, okay, is my chance of not being transplanted and dying more than that? Because you want those things to be balanced off. So I think that while transplant has its place, I'm always very cognizant to be careful about selecting it, because I think there are other pathways to go. It isn't something you should undertake lightly, but there are definitely times when it's clearly the right path. Okay, so what circumstances is rehab possible? This will be the remainder of my talk. And I'm going to tell you that, as Obi-Wan said, many of the truths we cling to depend on our point of view. So if you looked at this field 15 years ago, people would have told you all kinds of things that are not possible. They would have said, if you have jaundice, you can't recover, you're going to have a transplant. If you have X amount of bowel, you can't come off of TPN. If you have, so everyone tells you what you can't do. Right? They say, this doesn't work. Nobody on pseudo-obstruction can ever come off of TPN. This never, everyone will tell you what you can't do. And you have to abandon that. You have to forget it all, and you have to say, no, I just don't buy it. Let's figure out what's wrong, let's get to the core of it. We're pretty good at that a lot of times. So just to give you a sense of where the field is at roughly, this is a paper we published a few years ago where we were looking at our shortest kids. So we looked at 27 kids, and these children had an average of about 13 centimeters of intestine. So that's a piece of intestine, small intestine about that big. Okay? And they should probably have 250 centimeters, so we got 13 centimeters. And what we showed in this is that 50% of those patients in 2 years are off of TPN. So if you would have looked at that years ago, you would have said, everybody with under 30 centimeters of bowel, 100% for sure will die unless they have a transplant. That would have been, not even that long ago, people would say. There's probably still plenty of places that would say that. The reality is the data doesn't reflect that. If we can keep children going and we can keep them healthy, they'll adapt. And so it's incredible how well we can do as time passes. And we're starting to learn all these cool things about fermentation and cold burning and different ways we can get calories in. So this no longer, being short that doesn't necessarily mean it's a death sentence or it's guaranteed that you're going to transplant. It's quite the opposite, because what we can do is crazy now. Just to give you a rough sense of adults, and this is published data. So this came out a year ago from a guy who's sort of a pretty big name in Europe, this guy Loris Peroni. And they said that when they looked at their data, they said about any adult most adults with 75 centimeters of intestine are going to gain enteral independence. I think we would probably go lower than that even. I think that most people, depending on how much large intestine you have, you can go shorter than that and you can still do quite well and come off of TPN. And there's stuff in between, but there's also a ton of stuff that's going to change in the next few years. And so even these numbers, I did a talk a few days ago on how this has changed over the last 30 years, and it's interesting to see papers showing how short you can go, and it gets shorter and shorter and shorter. So why is this? Why can we be successful? Well, for us, one of the biggest things is institutional acceptance. This sounds lame, but it means everybody buys in. So everybody, I'm not trying to sort of talk on the rest too much, which you're all welcome to come. But everybody gets it. So when you go into the cafeteria, there's little kids all over the place with feeding tubes in, and nobody thinks twice about it because everybody has one, right? So that they'll go up and they'll order like an ice cream, and the lady behind the counter goes, "Oh, sweetheart, you're not supposed to have an ice cream today," and so everyone's behind it. So the whole place gets it, from the cleaning staff up to the CEO. I think we've got to a point as a team where everyone has a multidisciplinary team, and that's awesome. But if you want to get into this, you have to be so into it and so passionate about it that your roles blur. So my role on our team, we're a very dietitian-forward team. So our dietitians are really at the forefront of what we do. And I would say it's very difficult at times for us to tell the difference between who's the surgeon, who's the dietitian, who's the gastroenterologist, and who's the nurse coordinator. We're all in the room simultaneously. Everything gets generated as a team. So it doesn't matter who does what. Everybody does it all together. I think we're always looking at what we do because, we'd like to think we're pretty good at this, but we might not be the best. Somebody might have a brilliant idea, so why would I not do what they're doing? If somebody else has figured out something better than me, I'm all over that. Let's switch. Let's try things. I think we try to get out and publish our results because we want people to look at them and go, we don't buy it, or yeah, that's a good idea, and we want to see what other people are doing. And finally, we spend a lot of time talking to other people because we want to know. You'd be surprised how much stuff we've picked up from Facebook groups. The whole movement in short bowel syndrome towards constructed feeds and real foods and all that kind of stuff, a lot of that is driven from the social media groups. Because people are saying, well, my doctor's put me on tube feeds, but when I ate this, my poop solidified. And if you're not paying attention, you don't notice that. And you stick to doing your tube feed that you've done forever, when what you really should do is throw in some green beans, and you should throw in some oatmeal, and you should throw in some puree chicken, and you should get a constructed feed, or you should get a blend breast feed. Okay, so what are some things that are different? Why are we doing better and better? Because I want to give you a sense of what's happened over the last few years. Well, line care. So good line care saves lives. So everyone who has a line in this room, your point about being an advocate, you should absolutely be the biggest advocate for your line. If somebody is doing technique to your line, you should not let them touch your line if you're not doing it right. So if you scrub that hub for 25 seconds every time, nobody who doesn't scrub the hub for 25 seconds should touch your line. Right? You do what you need to do. You be the person who protects that line. If you go into a random emergency department in a small town and they don't know, and someone who clearly isn't sure what's going on comes up, you say, no, just wait a second. And you don't have to get all up in their faces, you said. You can do it in a nice way, but you can say, hey, here's what we need to do. Some people carry around a little information card. For us, a lot of times, we just have people call us. So you can call and get one of the coordinators on the phone. They talk to the emergency nurse and they go, hey, here's what you need to do. That's called an NICU. You can pull it out. Here's the different things you can do to fix things. So what do we try to do? Some of the simple things, we used to pull lines out all the time when they were infected. Now we don't pull lines out very often at all. We try to preserve lines and treat tube as much as we can. We used to rotate sites around. Now we try to use sites as much as we can rather than rotating because we don't want to incur injury in lots of different places. We tend to use chlorhexidine impregnated dressings. And we've moved towards trying to use some sort of microbial reducing strategy. So ethanol-lox is fairly common right now. There's actually something in Europe called trolladine, which we can't get yet, but we're going to see if we can talk to the company and start doing some trials of trolladine, because I think they get pretty good results with maybe not some of the issues that we get with ethanol. And ethanol log, for any of you that don't use them, just so you can mention to your care team if you don't have one. It's basically taking some percentage of ethanol, and we vary. We're actually cutting down our percentage. We used to do 70, I think we're down to about 30 now. But it's taking some ethanol and instilling it in your line when you're not using it. The idea being it sterilizes the inside of the line. You could let it dwell in there as long as you're not running, and then you just could withdraw it out, or heck, you could, the reality is you can push it through. I mean, if you think about, if you have a 1 cc line volume and you flush through 70% ethanol, it's about 2 teaspoons of beer, so you're a little flush. If you're a little baby, you know, maybe babies are, but for the average adult, Joel, I said, it's something we're going to look at. This is just a placeholder for me to remember to talk about feeding, because it's funny that, I'm not going to go into it because again, it's like a full hour's worth of talking or more, but we spend so much time talking about diet and feeding. It's a picture of a baby, but it's just as important in adults. So we spend tons of time focused on patterns of eating, how you should eat, what are the good things to eat, what are the good things to avoid, how do we create a diet that is enjoyable, right? Because it's one thing to come to Nebraska and me to tell you can only eat these 5 things, right? Nobody does that in real life. So if you come into me and you go, I drink 6 Mountain Dews a day, I'm going to say, well, it's probably not the best thing to drink. You know, if you can't stop drinking Mountain Dew, instead of 6, can you drink 2? And if you're going to drink 2, can you put a pinch of salt in? Just grab a little bit of salt, put some salt in Mountain Dew. So even if you're going to do something that I don't think is a good idea, at least it doesn't suck as much if you put some salt in. So, you know, it's trying to create a real world plan that's better than just doing nothing. Okay, lipid management. One of the things that's most toxic to your liver and your TPN is the kind of lipid that you get. So the commonest lipid that we use is soy-based lipid in North America. And soy, if you eat it, it's perfectly good for you, but it's not meant to be given to you intravenously. And so it paralyzes certain transporters in your liver cells, prevents them from excreting bilirubin efficiently, and so it builds up and it's kind of inflammatory to the liver. And so there's a whole pile of literature that's really come up over the last 10 or 12 years. And a big sort of field change was the arrival of fish oil emulsions and megamin. Megamin was this lipid that came available that's made of 100% fish oil. And if you've got TPN cholestasis and you go on megamin, it seems like for the majority of people that yellowness goes away. So that's desirable. And so we got on board with this just like everybody, you know, gosh, however many years ago now, 12 years ago or something. But we did learn more things as time passed. This was a little boy, Logan, who came to see us. And we were told, you know, came from another hospital, and they said, oh, we've done everything there is to do. This boy needs a transplant. He has to be on magical Omegavan. You know, that's the only solution he has. And so we took him over, and just this is the graph that shows you kind of what the bilirubins do from the original paper. So we took over Logan, and we started looking after him, and lo and behold, we were able to get the exact same graph. So you think, well, that's great. But we never actually put him on Omegavan. All we did is we just said, well, he's actually getting a toxic amount of this soy-based stuff. Why don't we just stop that? He doesn't need it for right now. Let's just stop it altogether. We stopped it, and we got the exact same result. And the reason that's important is because that shows to the field, it's not so much that the fish oil is doing something magical. It's that the other stuff is probably toxic, and by getting rid of the toxic thing, you do better. So what the fish oil allows you to do is it allows you to spare the more toxic soy lipids. So what we really should be talking about is soy minimization. So everybody got all jazzed. Oh, there's Logan. This was, now you can see. So Logan, this is 2012. I love this because you can see this. I took this a long time ago. So now, you know, he's been off TPN for a long time. So now he comes to clinic and he's like in 7th grade. He won't even look at you anymore. I'm like, dude, remember all these days? Remember we were a baby? So it's fun to watch them grow up. When this stuff came out, boom, headlines all over the place. Nothing in TPN makes national headlines like this had, right? You know, life-saving, it's a miracle, it's magical. But the reality is, oh, it's not even the hottest thing anymore, to be honest. So there's a new product out called SMOF, which is a blend of soy and MCT, which is like coconut, olive oil, and fish oil. And I must say, we switched wholesale everybody over to SMOF, so we don't have any patients on a lipid other than SMOF. Now you could, different people can do different things with their teams. I'm not saying that what you're doing is wrong. That's just the choice that we chose to make. We actually just stopped our Omegavan trial completely and just stopped using it because we feel like this gave us the same benefits. I think the data reflects that. And it has a little better profile of essential fatty acids. So if you're not on it, it's something to think about. And again, it's not to say it's the end all be all. It's just something to consider. If you're already minimizing lipids, it might not make a difference. on intestinal growth factors. We'll talk about this. This is something that's been a big change in the field as well. So we now have these analogs of glucagon-like peptide 2, GLP-2. So teduglutide, Gattex, is the one that we presently have on the market. So they're usually done as a daily injection, and the trials are designed to show a specific endpoint, and a lot of this relates to the language that the FDA requires and stuff. So they're designed to show a 20% reduction in TPN, and they show that. But the reality is, if you use it properly, and you use it in the right circumstances, patients can do very, very well with this. Likewise, if you go on Gattex and you drink 6 Mountain Dews a day, the Gattex isn't going to make a lot of difference because bad habits and bad other management will trump the effect of that medication. So if you get your ducks in a row and you do the other things right, these things are transformative in the way that you can feel and in your ability to come off of TPN. You just can't throw it in willy-nilly. You have to do it in the context of a team. So I won't get into it. When we talk questions, I want to go back and talk about the whole small-town doctor thing later on when we have a panel discussion, because I have lots of different thoughts. Okay, so we're getting into surgery. The best teams get jammed up sometimes. Okay, so when you get jammed up, that's where the surgery part of things come in. So what are some of the things that I think are important? Well, I think it's important to restore continuity early. So we're big believers in trying to get every bit of biology out on the inside back up again. So we don't have a lot of patients with ostomies. We tend to get things joined up. We're pretty aggressive at getting to the operating room and getting joined as quick as we can because we want to get food past that intestine. But you have to realize when you're going along, you have to realize when you're stuck. You know, so maybe you're doing awesome, you're doing great for a year, 2 years, 4 years, but all of a sudden it's not so great. You know, you're more distended, you're more gassy, food's not as good as it was, food frequency has changed, all this stuff's different. Then you got to figure out, you got to circle the wagons. That's when you got to do a contrast study, and you got to do a scope, and you have to figure out what the problem is. Often we get dilation. Okay, so dilation can really throw the brakes on everything on all your progress, and you have to deal with it. I'm going to tell you just a little bit about why dilation is important. We count on the squeezing motion of our intestines to push things through. Okay, if you take any hollow structure in your body and you stretch it up, and when it gets big, it's trying to contract, but it's just kind of wiggling on the edges. And so you have this intestine that's sloshing stuff back and forth, but it's not propelling it forwards. So then all of a sudden, it's kind of noxious to the lining of your intestine. The bacteria are overgrowing because they're not being flushed away. All these different things are going on. So you'll hear people talking about SIBO, you know, about bacterial overgrowth. Having bacterial overgrowth is like having a bruise. It's a symptom of something else that happened to you. It's not, it in and of itself isn't a primary problem. It's occurring because the bacteria are looking at their environment and they're going, oh, this seems nice. You know, not pushing me along, there's lots of food here, it's warm and moist, I'm just going to hang out. You know, when we say bacteria shouldn't be there, that's us projecting what we think about bacteria. Bacteria don't see themselves as good, bad, or otherwise. They're just responding to what we do with them. So the problem is often dilation. If you think about dilation, think about a big pipe, okay? Fluid flowing through a pipe, most of the fluid in the pipe is not touching the sides, it's coming through the middle. So that's your poop, that's just shooting out the bottom, so all your nutrition and everything else is gone. So if we can take that big pipe and make it a smaller diameter pipe, relatively more of that is touching the sides. So we change the volume to surface area ratio, and that helps you to absorb better, and it helps you to contract better. And I'll show you just some surgical stuff now. So these are just all the different kinds of operations that we can do. This is from a book chapter I wrote last year, and I'll show you each one of these in brief. So this is something called a step procedure. This was a little girl that we did this on. She was 9 years old. Actually, she was 11 at the time. That she had volvulus when she was 6. She came to us when she was about 9. So now she's 11. She's got this big dilated intestine. You can see it's about 8 centimeters. Should probably be about 2.5. So I'm measuring it, and this can't contract. It wants to squeeze, but it can't. So I'm taking a little Foley catheter, passing the Foley through it, just looking for narrow spots, suctioning out all the goo and fluid on the inside. I'm just getting everything all ready for the operation. And now we're going to do a step. And in a step, or serial transverse enteroplasty, what we do is we use a series of alternating staple firings. So we have the stapling device, and it fires rows of tiny little staples, a millimeter or 2, and then it cuts between them. And you'll see, as I'm going to lift this stapler away, you're going to see the tissue's going to open up like a V. Okay, and you'll see this V. It's firing right now. I can tell it's shaking. And then as I take it out, pop it off, there's that little V. Okay? So now I can come at that from the opposite direction, and I can make a V the opposite way. And we can have a series of intersecting V's back and forth and back and forth. And it'll become much more evident to you just in a second when you see when it's all finished. But in effect, what it does is it takes that great big dilated pipe and it turns it into a much smaller diameter zigzag pipe. And I'll show you just, I think I showed you in about another 5 seconds or so. And by doing that, by reducing that lumen down, the fact that that bowel can squeeze just a little bit is enough. That's enough to allow it to squeeze effectively and to start to peristalse. So now you see there's that zigzag intestine, and if I'm flicking it, it doesn't project too well. But if you were there, you'd see I flick it with my fingers and it peristalsis, and waves of peristalsis go around all the step loops, and so you immediately restore motility. And so you can see this, you can see the improvement in function typically within, by the end of the hospital stay. All right, let's move on. Okay, so here's a different issue, or a different way to approach things. Here's a gentleman sent to us with pseudo-obstruction. Awesome guy, from New Mexico. 48-year-old man, and he's, so for years, distended, pain, vomiting, he's been on TPN for years, totally healthy, fit, gainfully employed guy who now is, victim to all of these problems that he's having. And he's gone to a bunch of places, and they've said there's nothing that you can do. You have pseudo-obstruction, right? Doctors say there's nothing you can do because we don't understand it. So there's nothing we can do, so this is the way it's going to be. And, you're either going to get complications, need a transplant someday, or, just suck it up, and then we'll just decompress as best as we can. There's a copy, a picture of this CAT scan just showing these massively dilated loops of bowel all throughout the intestine. Well, we decided that rather than just accepting that as gospel truth, we were going to do something different called a long segment tapering angioplasty. And the idea there is, this is a gentleman who's got plenty of length of intestine, but it's not working because it's massively dilated, so we need to give him a much smaller diameter intestine. We need to make it a more normal size. So how do we do that? Well, we can take that great big intestine, put a series of clamps on the outside. You can see how massive that is in the picture. And we can get rid of all that excess. So in the center, you'll see now the bowel that's left behind, that we've left at a normal diameter with a long staple line all the way along the antemesenteric side. And all that extra bowel, that's what 8 feet of excess intestine that's just removed and discarded. And so this guy now, he's doing awesome. So, it probably took him 3 or 4 months to recover fully and get his function back, but now we get the video of him throwing pitches at the baseball game, he's back to work, he's eating, he's off of TPN, everything's going okay. Now, I don't want you to think that this is magical, because by me reducing the intestine down to a normal size, I haven't fixed the underlying problem, right? If there's a genetic cause, and I believe I have some inkling as to what the underlying cause is for him, but I haven't addressed that. But what I've done is I've addressed the mechanics of the problem. And so while we're still, as a field, trying to figure out the genetics of the problem, at the very least we're taking care of the mechanics and restoring quality of life and getting this guy back to feeling good again. And I'll take that, because we might discover something awesome in 5 years. And so far, we've been doing this for many years now, and I must say, most of the patients we've tapered really don't redilate over time. So it's possible they could dilate 5 more years or 2 more years or something, but we'll cross that bridge. This operation is set up in such a way that we can do it again. We can still do a step, we can do another tapering. So fistulas, we have to do a lot of complex abdominal surgeries, just putting stuff back together again. This is just getting familiar with doing horrible things. Tough surgeries that take many, many hours. And a lot of surgeons will say, your abdomen's frozen. You can never be operated on again, and what you have is what you have. And it's all a question of where you live. If you live in abdomens that are frozen all the time, and you're always doing this kind of stuff, not to toot my own horn, but you get pretty good at it. And so I feel very confident that there's not a lot of things that I don't think we can take care of. If people are obstructed and they've got terrible, nasty abdomens, we can fix all of it. Okay, so the future. Last little bit. Where are we going with growth factors? So we want to take this little guy and we want to make him into the big guy. So what's happening with teduglutide? Well, so teduglutide, or Gattex, has been out in the market for adults for quite a while. We just completed the pediatric trials, and we're sort of in the process of publishing the results and publicly presenting them at meetings and stuff. So we're hoping that we're going to see Gattex for children freely outside of the context of a study. I'm hoping sometime in this calendar year. We don't know for sure because it's all the FDA, but we're hoping in this calendar year. And then there's a different medication called glepaglutide, which is a sort of an alteration of that GLP-2, and it's probably going to be like a once-a-week injection. So there's a clinical trial just starting on adults, and so we're the lead center in North America, in Nebraska, and we'll be randomizing our first patient probably in about 8 days or so. So I was at a meeting about that this week, and so Europe is starting and we're starting, and we suspect over the next couple of years that trial is going to be ongoing. So I guess if it's something you're interested in, you can get a hold of me and we can either talk about doing something in Nebraska or there's a doctor locally who would be recruiting, so either would be fine. I just want to help out however. The microbiome, I love this, and this is, I thought I was doing an hour talk, so I had like an awesome 20 minutes on microbiome. I cut it out right before I came up. It's super, super fun, but I had to cut it out. So the microbiome, just in very brief, so you've heard of it, is the bugs in your body and the environment they live with. So specifically for most people in this room, it's the gut microbiome. It's super, super pivotal to how you feel and all kinds of different things. And if we get a chance later, maybe even in the panel discussion, I'll just tell you some cool stuff about the gut-brain microbiome axis. But it can sometimes help people to explain why your mood, why your emotionality, why your thoughts can be impacted on directly by what's going on in your gut. So it's not just, oh, I'm feeling crappy because my stomach hurts. You may genuinely have, the bacteria in your gut will generate neurotransmitters, and they get absorbed by your gut and they go up to your brain. So if you look at serotonin, like that, happy hormone sort of thing, if you look at some patients, 80% of the serotonin in their brain is gut-derived. So you're not making that yourself. The bacteria are making it. And so the bacteria are controlling whether or not you feel good. And so this becomes very germane into how we stay healthy. But it also has a lot of implications for where we could go in the future. This is an interesting point. In your body, you have about 10 to the 13 cells, but you support about 10 to the 14th bacteria. So genetically, you're 10 times more something else than you are yourself. And it's always fascinating to think about it that way, because you think you're you, right? You're sitting there having your coffee, you're eating your eggs. And the reality is there's 10 to the 14 things. You're like a vast universe, and they're all living on you, and they don't know you exist. They just think, wow, this is the nicest place we've ever been, and they're coexisting, and they're multiplying, and they have these huge worlds. And they're changing stuff all the time with us. Why is this important? Well, we're learning more about this, and it's still in its infancy. We're pretty much in the naming stage. But this, for example, is commercially available poop. Okay? So this is typically used for C. difficile. The little one up in the top corner is for injection during the gastroscope, the bigger one is during the colonoscope, and then the last one is pills. So you can actually do a stool transplant by taking all 25 of these pills. You have to take them all at once. They do have a little bit of a poopy taste, so you just have to pinch your nose and take some orange juice. But the point of this isn't, we're not worried so much about the C. diff style treatment as the notion that we'll get to the point where we can manipulate the microbiome, so we can create an energy extracting microbiome. There's evidence to show there's obese microbiomes and lean microbiomes. So an obese microbiome might make you obese in the general population. You might say that's not desirable, but if you have short bowel syndrome, you want an obese microbiome because you want to be energy extracting. So we have to figure out what that means, and we have to push towards getting to it. And we'll get there. We will get there. We've got some studies ongoing in this to try to determine what that is right now. And I guess in my final few slides, one of the last things for us is changing. I know. One of the last things is, I think I have 2 slides, is the way we actually provide care. I told you a little bit about how our program works. And I think what we've come to realize is if we want to be successful, we have to get engaged inside somebody's life. And we have to hold them tight. Hold them tight to plug and be part of things. So this is just our one model house. Most of our house is filled up with kids that are in intestinal transplants or short bowel syndrome in the rehab program. And so just simple little things like we have 20 rooms, we're expanding up to 40 rooms, so we're putting our clinic, our short bowel clinic, right in that house. So that way if you come, you can just roll out of bed in your pajamas, trundle down the stairs with your kid. You don't have to, crawl through the winter over to the hospital or anything else. Because we realized that this was becoming a community of people with short bowel, and everybody was learning off of each other and supporting each other. And we thought, well, why are we separate from that? Why are we in the hospital? We need to be part of that community. We have to all be together in the fight. So we're going to move over there. That's going to be probably about 6 months. So in the end, transplant and rehab should work together. We should strive to make transplant unnecessary for children and adults. That's what we should shoot for. We may not achieve it. There will be some people who will need transplants, but we should always push to not do it. And as I hopefully imparted on you, what seems true today may very well not be true tomorrow. And so there's always hope. You should never, never, never think that you're stuck, and you should never give up because it changes all the time and it gets better and better. All right. Thank you very much. I think we'll have
We're going to have a panel discussion right before lunch that you'll be able to ask Dr. Mercer and Dr. McCullen and Lauren any questions. So we'll save that till the end.
And I'll be around. I don't have to leave till about 2, so I'll have lots of chance to talk if you want to talk.
Okay. Please, thank you, Dr. Mercer. Please help me welcome Dr. Richard McCullum, who will be talking on severe gastroparesis is now curable.
No, I really enjoyed that presentation by Dr. Mercer.